to learn who was listening in and in what way we can be in touch with them, since they are interested in what we have to say. Now, I've been suggested that I should speak about the community care in the year 2023. And I think that we have to remember that in the middle of the past century, 20th century, there was a number of important statements that have been made to create a strategy, postulates of mental health care, how it should be done. And one of the things which was quite clear is what the mental hospitals, which in the past have served sometimes a good role and very often been neglected and therefore fallen into a state of disarray where the patients had a very bad time. But that these mental hospitals should be closed. There should be people who have mental illness should be treated in psychiatric wards. The psychiatric wards should be placed into general hospitals. We should have an opportunity to see that people who have mental illness are no different from people with other illnesses. They should be treated as for their acute conditions and for their significant acute symptoms in the hospital, and then placed back into the community as soon as possible. The communities, on the other hand, have to be prepared to accept convalescents and to think about ways in which they can help them and offer them an opportunity to be included as the members of the community with all the rights and all the other things that are usually offered to people with who are members of the community. There was a number of efforts to ensure that the communities, in fact, do help people with mental illness, and they should make it possible to people who are in the community but have to go to see a doctor nevertheless, or if their condition is reactivated in one way, to go and see their doctors. It was, for some instances, it was clearly understood. It was said that people who are have no more family or have not been a member of any community for a long time, they should also be given care. And in a number of countries, they created one form or another what was called social homes. And these social homes were to be accepting people who are not mentally ill, but who have in one way or another been damaged by the mental illness and have a handicap of sorts and needs to have some steady support. And these are to be in these social homes, which have been created in some countries in very large numbers. In a country like Slovakia or Ukraine, for example, there were considerably more beds in the social homes, where there were not only made people with mental illness, but also people who otherwise needed help were located and placed to make it possible for them to continue living. Another set of recommendations of the mid-past century was that mental health should be provided by general practitioners, and that we should teach the general practitioners how to provide care, particularly for the common mental disorders such as anxiety or depression, but also for other disorders. We have done in a number of studies in which we have demonstrated that primary health care practitioners can in fact provide significant help to people who are mentally ill, recognize their illness, provide them with some treatment, provide them with advice. And so this was another main line of argument that was there. No hospitals, active, well-run departments of psychiatry, transitional institutions, and communities which accept people and look after them. The last one of the idea of that general practitioners should be in fact participating in training. It was felt that the education in psychiatry was often during medical school not particularly practical, and therefore it was important to train the general practitioners in the recognition and treatment of at least the common mental disorders such as depression and anxiety. And a number of efforts have been done in this respect, including the very important investment of the World Health Organization, which has been promoting the MHGAP set of programs which are helping people to learn how to deal with mental disorders when they discover them. And it was also felt, and it was promoted, that the other people who are not doctors, but who are invested in the health system, should also be trained and exposed to a decent training, since they didn't have it very often before they started service. It was proposed and promoted that the in-service training should be taking place in all of these different professions, which can contribute such a very important part of care to the mentally ill. So these are more or less the principles which were with us in the 1960s and 70s. It continued to roll on with these same principles, and even today, when you look a little bit to see what are the strategies that we are proposing, and more or less these same principles are being promoted, and the role of the community in looking after people, most of the time, with the exceptions of the short periods when they are struck by an acute illness, the communities were to carry all this. And then what happened? Well, in many mental hospitals in high-income countries have been closed or reduced in size. There was a number of hospitals. I remember one in particular, which I visited for quite a few days. It was a hospital called the Pilgrim State Hospital. It was a hospital with 13,000 beds and 14,000 staff, a village or town, if you wish, on its own, living about 15 kilometers from the other people in the surroundings. There were a number of similar hospitals of that size in various countries, very large, very often with a complete and enormous economy that goes with it and so forth. Well, in many countries, these hospitals have now disappeared, have been closed or diminished in size. And at the same time as these big hospitals have been closed, private hospitals of a small size have sprung up practically everywhere. Italy is a good example for that. In Italy, there was a very famous law which said that all mental hospitals have to be closed, which they did. And all the government-run mental hospitals have been closed practically from one day to another. And when they looked at the total number of beds which were available, they saw that the reduction in the number of beds was relatively small, because while the government hospitals have all been closed, private care and private hospitals have grown in size, in number, and importance. And many of the people have, in fact, found their place in these hospitals if they could afford it. If they couldn't afford it, well, they've ended very often in the street or somewhere else. Now, we have done ourselves in the time that I was in WHO, a very large number of training courses for general practitioners and some other staff. Some of it worked very well. The general practitioners were keen to learn how to deal with some diseases, not with all. They were quite happy to learn about ways of treating depression, for example, but less happy the ways to treat, for example, schizophrenia and some other psychotic disorders. So nevertheless, they learned quite a bit, and that was an important thing. And psychiatric wards have in fact been created in a number of hospitals. Very often they were them in a way showing the attitude that people had towards them, that the mental hospital was in the ground floor, but very often in the what you call it, the souterrain, the floor under, or in a place in a corner of the hospital complex. Nevertheless, they were hospital, and they were very actively working and seeing many patients, and they were quite obviously very useful. Now, the problem was, of course, that the mental hospitals, which are very large, when they were closed practically overnight, very few countries have in fact provided sufficient something that would keep these people who came out of these hospitals, very often handicapped by a long stay in a rather terrible situation. They forgot how to live in a community or in life outside. And so many of them, in fact, ended up by being found as vagrant or traveling from one market to another and eating garbage that was left over after the markets were closed. Some others were, in fact, almost without knowing, having unlearned how to live in a community or in a society, finished in a prison. And people are talking about not of deinstitutionalization, but of trans-institutionalization, because the people who were previously in a mental hospital sort of shifted into the prisons and were kept there for varying amounts of time, very often on multiple occasions, because as soon as they left the hospital, the prison, they were again committing something. And by that time, they already had an indication that they were previously in the prison. So it was even easier and normal to, so to say, put them back into prison for a while. The principle of community care, which has been very clearly stated, has in fact become a bit difficult, because so many communities did not care. And not only that, but it's also important to recognize that the last 40 or 50 years have been marked by very rapid and major social change, which was due to urbanization. Today, you have a country such as Argentina, in which 94% of the total population lives in towns. And most of the people who came to live in towns have in fact appeared there on the doors of the towns in the last 20 or 30 years. They come on their own. They don't know other people. They don't know what the town is all about. And they certainly are not a community that is helpful and help other people who are mentally ill or in other ways unwell. They don't have family relations, which are usually in extended families. There were numerous members who were living in the same geographical area, and they could all contribute and participate. But these very large families in urban settings have started becoming smaller and smaller. There's families where very often a 3-member family or a 2-member family, sometimes with an extra grandfather or grandmother who were left over from somewhere, very often, however, living separate from them. And the idea that they could accept another patient to look after them alone was not particularly popular. I live in a town now, and I live in a house which is 10 stories high, and we've been in this house for 10 years. Now, in these 10 years, I have met, and usually meet, one person. And that person is, I meet him because he takes his dog for a walk early in the morning. And I usually go to the office at the same time. So we meet in the elevator and we say hello to each other and ask him how his dog was doing. And he tells me that the dog is doing fine. And by that time, we have arrived at the ground floor, and he goes and walks the dog, and I go somewhere else. Now, that's not a community in which I can, for example, had a bout of schizophrenia, it is extremely unlikely that he would leave everything and start helping me. And the other people in the house, I don't even know them. The community, which was originally described by people such as Griesinger, for example, in Germany, who in 1842, having come back from Egypt, was impressed by the fact that when somebody was ill in Egypt, everybody in their surrounding, a large family, as well as everybody in the village, was very concerned to do something and to help him. But the communities of that type that were present in villages at the middle of the last century, the 19th century, have disappeared. They are not there anymore. In large towns, there are no communities in which people know each other, are willing to help another, have long-term relationships, go to each other's marriages, go to each other, other celebrations, etc. These communities have by and large vanished. So this is a situation which is very different from the principles which we had in the 1950s and 60s and 70s. The social institutions, the social homes, which I mentioned earlier, and similar institutions which have different names, have been very often misused. In some countries, they have forbidden the people who are in the social homes to leave their social homes, because when they left their social homes, the owner of the homes would not receive the money from the government, which was given for care of people who are present in the place. So they were locked up in the social homes without any care. Many of the social homes had no a permanent doctor or other medical person who was present. Tuberculosis was rampant in some of the countries' social homes without any control for it. So that the social homes have been misused very often or mismanaged and have not done what people were hoping they would do. The joint families, which were previously composed of 3 layers and of many other friends, etc., who have been mutually supportive, have vanished and have been now replaced by a very large number of very small families, which we see everywhere. Not only have they been replaced by small families, but they've been also replaced by a number of people who are living alone. In London, in a relatively recent survey that was done, people found that 26% of all households were single-person households, a person living alone. And in a number of other countries, for example, in China, special legislation has been issued punishing the children if they do not look after their parents sufficiently well. If they are living in the same town and they leave the elderly parent of one or the other member of the nuclear family on their own, they don't want to go there, they don't have the time to go there, they have many other tasks and duties, and these people are neglected. So the government decides what they will do. They will pass a law which will punish them if they don't do it. And other countries do similar things, even in countries which are poor, poor being low income. For example, Bangladesh has recently passed a law as well, in which the care for the parents is an obligation which has to be fulfilled by the children, or else the children will be punished. But that is an important situation in which we are finding ourselves, that these previously large families, which could without any problem accept yet another person, have by and large vanished in most parts of the world, even in very poor places. Very poor places, I say, well, these are countries which have low income, in which many people have moved into towns, slums, and live in the slum surroundings. And the slum surroundings very often do not have large numbers of the same family, but have many families. They know each other and live close to each other, but the obligation and the sense of duty that people previously had to help one of their members who is unwell has by and large vanished in those settings. Most of the urban dwellers avoid contacts with others living next to them. They are afraid of them. It is not least also to mention that many of the people who are moving to towns are in fact what one would call inter-country recent migrants. And migrants always have a big problem to establish themselves and to establish contacts with the local population. And they are certainly unlikely to accept people whom they don't even know and to look after them in a setting. Now, it is not to say that there are not corners here and there in some of the countries in which the communities are a little better maintained than elsewhere. But in the large majority of countries, there is a continuous process of disruption and diminution of the size of families and the disintegration of what we previously knew as a community. The consequence of that is also that despite of all our efforts to train the general practitioners and to do something for the various people, still about 4/5 of the total number of very serious people, serious mental illness, is in fact not receiving any treatment at all. But what is even more important at this point is that in the highly organized and highly developed countries, which are of a high income, 20 to 25% of the severely mentally ill people do not receive care. Because even the government has its limits to which it wants to go, and there are the carers as such are not, the community as such, which could receive people and give them all sorts of help, very often is not prepared to do it. There are, of course, some promising developments as well at the same time. In some countries, for example, the peer support has been gaining strength. It has started the peer support with people who were addicted to drugs or to alcohol, and the Alcoholics Anonymous and similar organizations have been doing a very useful work. They have been helping one another, and they have been taking sort of responsibility for one person to help them to overcome the crisis, etc. And similar peer organizations have now sprung up for diabetes, for cancer, and for certain mental illnesses. And these peer organizations are doing a wonderful job. I must say, the peer organizations are done by peers who are not getting any money for it. They are sacrificing their own time to help these other people. There is even a world organization of peer support organizations which tries to organize, and that is a very promising development. But it's not a solution by itself. While we can hope that some of the peers will help some of the people who are mentally ill, that does not cover the large majority of people who are living this. Not to forget to say also that the doctors as such are very often not particularly close to the peer organizations. We have been working in several countries trying to revise in Central and Eastern Europe, trying to revise the services. And one of the difficult tasks which we had was that the doctors who is discharging the patient should not only know who the peer support organization is, but also that they should give them the patient the address of such an organization, to ask them to go and see them, to phone the organization and tell them there is a gentleman who's just coming out of hospital, would you be interested in helping him, etc., etc., etc. Now, I think that the difference, another possible thing that is very positive is that, in fact, in some of the families in which people have in the past very often shied away from the person who was ill, they have now found a way, particularly with modern treatment, to look after such people, and families have become, although much smaller, have very often been willing to sacrifice a lot of their free time, energy, and effort to help the people who are mentally ill and who have come home. The medications which have been used for psychiatry are cheaper and cheaper, and although they play only a part of the role, they're important to have them as well. And today, it is in fact for most countries possible to get these medications. In many countries, we see that the medications are offered free of charge, which is also very possible. The efforts to train general practitioners and other primary care agents have been successful in some countries, not in every instance. Very often it depends on the personal inclination of the primary care agent, whether he or she will want to do something with mentally ill people, or whether they will in fact reject them. An interesting reflection of the stigma that is very much at play here is also that some of the psychiatrists whom I have met, for example, in Thailand, have their plate of their name as a general practitioner, although they are fully trained psychiatrists and treat psychiatric patients as if they were in a psychiatric hospital. But neither the doctor nor the patient wanted to be known that they are having a mental illness which is being treated in this situation. There has been a gradual development also of the ideas that something has to be done about stigmatization. Stigma is one of the most serious and terrible problems on the way to any improvement of health care. In fact, the recent Lancet Commission report on stigma, which is freely available and certainly an excellent piece of writing, has reviewed the situation in many countries, and without any doubt demonstrates that stigma is still the #1 obstacle to making significant progress. This is the Lancet Commission was a thing done by a variety of people, psychiatrists, people with experience of mental illness, carers, and other doctors, etc. But in addition to this, there is now, at least on 2 occasions, 3 years ago or 4 years ago, before COVID in Holland, and then more recently in Paris, the ministers of health who have come together to speak about the progress of healthcare in general have recognized that the battle against stigma is a priority and have spoken about that and have done some of the work necessary to do this. And we are now also gradually saying and knowing that the public health importance of doing something about mental illness is generally recognized. People know now and believe us that this is a big problem, which was not the case about 50 or 80 years ago, when it was considered that only a few crazy people are moving around, and that is not a serious problem. The calculations which are being presented, of course, are clearly showing the enormous loss of productivity and other losses that mental illness produces. But at the same time, our argument that there are very mentally ill people is turning against us in a way, because the fact that there are so many of them around, in a way, says that the mental health system is not particularly effective in reducing their number. So that the argument there are 1 out of 10 or 1 out of 5 people is mentally ill is all right, but has to be accompanied by additional explanations, lest it be felt that mental specialists and mental health services are not very good at doing anything useful. Now, having said all of this about the situation at present, I think that we should probably think about what could be done in mental health care this year, now, immediately. Here are some of the things that many people have been speaking about. I think that we should not any longer speak about treatment of mental illness in vague terms, but should provide equally specific calculations as they are provided for any other public works. We are very often saying it can be done, but I mean, it's not can be done. One would have to say specifically how much it costs, where the cost comes from, how it should be handled, and what management we are proposing. We should stop thinking that we can get rid of all of the institutions, because some of the institutions for inpatient care are necessary. People, when they are acutely ill, very often can be better treated within an institution that is manned or that has personnel that knows what they are doing, and such institutions should exist and should be controlled very carefully for the quality of care that they provide and for the respect for human rights of people who are accepted to these institutions. But they are necessary, and they have to be one part of what Professor Thornycroft and others have called the balanced care system, in which we have a variety of institutions that work together. One of the tasks that has to go in parallel with this is to review the legislation which is related to mental illness. It is by and large worldwide very obsolete. There are very few of the mental health laws which are really up to date, and mental health laws which in fact contain what we now know about mental illness. And these legislations, in some African countries, for example, they are almost exact copies of the mental health laws of France in 1888. Now, this is more than 150 years ago. The world has changed so much that it's quite clear that these laws make no sense. Very often the laws are simply transcribed, and that means that they will not be useful. For example, there is a rule to protect the human rights. There is a rule that 2 doctors have to provide a signature if a person is to be admitted to mental hospital or mental institution against their will. But in spring, the distance between the first doctor and the second doctor is maybe 100 or 60 kilometers of mud. And they cannot get together to have 2 signatures put on the piece of paper. So this particular prescription, which was all right in a town in France, is not applicable anymore. And it is silly to speak about this, because they will either falsify the signatures or disregard the rule and proceed to do something to help the patient, to treat the patient. And there are numerous other things that have to be done. I always tell the story, which I think is so illustrative, of Spain, in which some years ago we went to see, and we spoke to the directors there of the hospital and others, and looked at these institutions, and discovered that one of the things that was prohibited was the eating of cheese in the hospital. The hospitals had their prescription for diet. We have examined those, and there was a prescription that there no cheese should be given to patients at all. Yet Spain is a country in which there are wonderful cheeses, and people like them and eat them as part of their normal diet all the time. we have tried to discover what it was, and finally we discovered, yes, this was because about 50 years ago or so, some of the medications that were used for the treatment of depression, MAO inhibitors, have in fact had bad reaction if they were eaten together or taken together with cheese. Now, the MAO inhibitors are make of the past. They don't exist anymore. But the rule is still present from over there for many, many years. And I think that if you go through the rules of hospitals and rules in the systems of care in many countries, you find a number of obsolete prescriptions which are disregarded. And the consequence of this is, however, that since the people look at the law and the prescription and see that many things are not paid any attention, they don't pay attention to any one of them. And many of the misuses of legislation and rules are due to the fact that these laws and legislations are obsolete and not controlled or not updated for many years. So my notion is in the legislation for mental illness, which is in an area that develops very quickly, one should think about a sunset clause. That is to say, this law is valid for the next 2 years. In 2 years' time, we shall examine this law to see whether anything as new has happened which can help us to make the law better, to improve it. It's very important to do this because sometimes the mental health laws will be in the making for many years. And to get it back on the agenda of a parliament is very difficult. The law on mental health in China took 22 years to be developed and approved. And if you want to change it, it may take another 22 years. It's a good law, but it may be something may have to be changed in the now or later or whenever. And these laws will then take a lot of time before they can be changed. Now, we should also think another thing that is now becoming a priority is training of healthcare and other professionals about mental health early on in their training. And this is not the training which should be done as we have done in the past. One of the features, for example, should be that we should train various participants in the treatment of mental ill people, various participants together. There should be a part of training of the doctors which is joined with the training of nurses, of social workers, and others who participate in training. Why? First, because they have to know the same thing. And second, because during the joint training, they will probably learn how to respect one another and work better as a team. And it's something that is easy to do, and very often, particularly in conditions where there are not too many good teachers, can help both the quality of teaching and the relations that subsequently happen. Now, to my taste, one of the chief priorities in the years that come before us is that we should think about providing more care and more support to carers. They are, in fact, the people who carry practically all of the service, not the community, the individuals who are in the family, one or two people who very often sacrifice their life to help somebody who is unwell. The number of, as I told earlier, the families have decreased, so the number of carers is smaller. And it's one woman who looks after maybe a husband who is not very well, and at the same time also an elderly father or mother who is slightly demented, and many other things in addition to everything else. It's a huge amount of work that is put on a very small number of people. Their numbers is very small. And what we know now is that they are more frequently physically ill. We know that they are, in effect, the care as such, the outcome in many instances, in many places of mental illness treatment is worse than it used before, because the care which is provided by carers is incapacitated by the burden on which people, under which people rely. And of course, that increases the cost of care. But there's another aspect of what we could do about the carers. We should think a little bit about providing carers also an opportunity that people know that that we respect them. Why do we not, for example, regularly, and that is a rare thing that we are seeing, why don't we invite carers to teach students about care for chronically ill people? They know much more than any doctor will ever know, unless the doctor had a mother or a father or a brother or a sister who were not well and had to be looked after at home. And this is never the same, because these people, the doctors, they themselves have other resources and very often more money than most of the families whom they treat. So why not invite these members of the families to come and teach students, speak to them, explain to them how they in fact have to look after people who are mentally ill. I've been surveying most of the countries of Europe to see whether there is any one in which there is a rule which says what must be the strengths of the family into which I'm discharging a mentally ill person. What is the minimum requirement of free time and of money? Because if I don't know this, if I just discharge the patient into the community doesn't care, the family cannot tolerate it, and very soon the patient will be back under worse condition. So the notion that we should have rules about what is the minimum strengths of a carer group that can receive a patient is something that could be and should be done very soon. We should, in fact, also recognize that there are various other things that we should mentally accept. We should understand that most people in the world do not live in mutually supportive communities, and that we have to think of a new structure in which we are working very closely hand in hand with the carers. We assess their capacity, we help them, we respect them. It's only the British Royal College of Psychiatry which has an annual prize which they give to the most respected, most effective carer family. And I think it doesn't cost very much to do something of that type, to have at least among the people who are there some sign of recognition of the tremendous effort that families and carers do. We should also not only assess the capacity of carers, but we should help them in concrete terms, in money. In some countries, there is a small amount of money that is given to carers to look after the patients at home. After all, they are taking the role of the hospitals. So it would be logical that the amount of money that was spent in a hospital for looking after a patient should now go to the carer who is looking after that same patient. In this instance, maybe the carer could hire somebody to help, or could reduce some of the extra work which they have to do anyway, or in some other way, he would at least feel also that he's respected, that his work is worth something. It's a tremendous contribution that family members will make looking after somebody. So we have to give them money or other support. There are some instances which are very beautiful. For example, in Holland very recently, they've changed the role in 2 districts of the social workers. Social workers are no longer having a room in the hospital. They are in fact giving care of 15 families. And they have to go from one of those families to another. Every day they have to see them, talk with them, help them to look after the patient, help them to deal with social problems. And in many families, they are seen as a son who is very knowledgeable, welcome at all times, and who helps them very much. We were wondering whether, in fact, the social workers will be willing to do this. And the reports which you get from these health workers, they are delighted. Suddenly their work has become a real work what they were trained for. They're helping specific people, and they are becoming member of that family. It's a wonderful experience, they say, and they like it much better than the previous style in which they were advising people about this, that, and the other, and dealing with the authorities only, not coming into the place where they got a cup of coffee and sat together and talked about things, and being an able member of that family who can and does want to help the person who is not well. I put it down here on this slide to say you should make money follow the person who needs care. It's not that you can keep the money and expect that care will continue. Somebody has to pay for it. And if somebody has to pay for it, we should think of ways in which we can support the person who does it so that he can continue living a normal life while helping people as well. A new problem that is emerging as well in these years is the problem of thinking how to help people who have comorbid disorders. Many of the people who have mental illness also have physical illness. Where are they treated? Very often there is nothing that is done about that. And they are very often suffering from both the physical and the mental illness. Collaborative care, which has been mentioned as an answer to this problem, works if the chief of the Department of Internal Medicine or the general practitioner is a good friend of the psychiatrist, and they can call each other. But otherwise, collaborative care is very often present only on paper. The Americans have even started introducing a new profession which will take the patient from one doctor to another when they have comorbid disorders. They call them care managers, because care has to be managed by somebody. So the notion that we should think of a different way of dealing with comorbid disorder, because up to 1/2 of all people with mental disorder also have a physical disorder, and vice versa, of course. And I think that that is something that has been neglected for a very much time. And as I mentioned earlier, it would be nice to think of some training that is given together to doctors, future doctors, medical students, nursing students, lawyers, and others who participate in training, policemen. Many of these people, in fact, should have a joint experience and meeting the other actors, finding a way to treat the policemen as a separate program costs money and time, but inviting some of them to come along for some of these training hours is very much easier and works equally well. I think that I mentioned the terms of employment of social workers, which are particularly important in thinking about the life of the person after he's left the hospital or wherever he might have been. I think that the continuous effort to think about ways in which we can reduce the stigma of mental disorders must be an effort. We have recently published a book in which we have reviewed the current knowledge about stigma and fighting stigma. And we were amazed in writing this, how many useful, cheap things can be done to reduce stigma. And I think it's a very important permanent duty of the mental health service to think of ways of reducing stigma. Not having campaigns. We have a campaign against stigma. No, because the campaign comes and goes. And after the campaign, people who are involved are feeling even more dejected and alone than before. It must be a permanent, continuous process of thinking about ways in which stigma can be reduced. And of course, it would be useful in thinking about all this to also listen to people who have mental illness or their families. What would you like most? We have done a survey some time ago, building a program in Canada, and we have done all sorts of things in the news, in the streetcars. There were various posters, and there was speeches on the radio, etc., etc., etc. And then somebody said, "Well, wait a minute. Let us ask the families to see what disturbs them most. Is it what people think about, or what is it disturb them?" And we went to the families, and the families told us what really disturbs us about the fact that my son or daughter has a mental illness is that when we get to the hospital doctors treat it as if we were dirt. We are seen last, we are waiting longest, all sorts of things. So we went to the hospital doctors and said, this is what complaints we hear. And they changed. And the families suddenly were feeling much better. They said, wonderful, they're willing to work further with us, etc. All of our stigma program that we have started at that time was much secondary to this one particular thing, which we managed to change and which opened the door to other things that could be done. Equally so, we should invite carers to help us plan our services, to think about, there are so many stupid rules that still exist. I know a particular thing was recently seen a plate that hospital, it was a mental health ward, and visits were permitted between 3 and 5 on 2 days a week. Why 2 days a week? And why only between 3 and 5? I asked them. They said, well, that was always like that. But that's not an answer that you can accept any longer. What was previously perhaps, for one reason or another, justified, has to be changed if the world has changed. So, ladies and gentlemen, I think that it is fair to say that the arrangements which we have currently about help with people with mental illness and particularly also about helping carers, are obsolete. I think that the fact that the traditional communities have changed and disappeared, and that the urban living is now the main form of living, requires a revision of principles which we are using in mental health care. And some of the key elements in this is support to carer, which must be a priority for action, particularly for chronic illness. Development of new types of care, such as the peer support, common dwelling, the Australian example of safe spaces, many other new and interesting core features. We must insist that the funds should follow. Care outside of the hospital is not cheaper than in hospital. It is equal cost. So we have to think about cost as well. And I think that we should also remember that we cannot have rules which are valid forever, and that we should think about changing rules very soon, every 2 years or every year, to make sure that we are in keeping with time, and that we can, in this time in which we are living, have rules which are useful for service, for our patients, and for ourselves. Thank you very much for your listening to me.
Yeah, hello. We're all back again. Thanks. Yeah, thanks, Norman. I think Sujit, I think you're there.
Yeah. Thank you so much, Professor Sartorius. This is actually, in fact, an eye-opening message for the audience. I want to discuss about a typical scenario in the developing countries, particularly the South Asian countries. Most of the South Asian countries, including India, they struggle with the number of mental health manpower. There is a paucity of manpower, and people struggle because of not having adequate psychiatrists, psychiatric nurses, and ancillary mental health manpower. So the number of psychiatrist seats has been increased by the government, and but unfortunately, what happens at the end of the course, many of the psychiatrists they leave the country and go abroad. They want to practice psychiatry in developed countries rather than staying in India. So even if the number of psychiatrist seats are increased, there is a draining of psychiatrists from the country, and this is not a unique problem to India. That is also happening in Sri Lanka. That is also happening in the other region like Bangladesh, Pakistan. So how to deal with this issue so that the manpower shortage can be addressed adequately?
Well, the first thing that you have to realize is that doctors, psychiatrists play a very minor role in the treatment of mental illness. We don't need them for as long a time as people think. What we do need is to really think of who provides care, and that is the carer. And we should think about how we can maintain the system of care by people who are with the family, etc. The doctor, we can do with even fewer psychiatrists than we have now. But what we cannot do anymore is we cannot do without the supporting people, for people, their brothers, their sisters, their family, others in the community. These are the ones who carry the disease burden nowadays. The doctors give advice, and they don't see the patient. You see, as a psychiatrist, you see the patient, as I know India, but I was working there, I saw it, and it's not changed very much. Most of the doctors see the patient for control about 5 minutes every month, or 10 minutes maximum. Well, a month has many minutes. We are paying attention to the doctors. We are not paying attention to who in fact does the care. And that is the switch which we have to understand. Now, you say many doctors go away, go to England. That is unfortunately a process, not to England, but to some other country, Australia or wherever. That is unfortunately a negative consequence of training people. The people in developing countries, in the low-income countries, have been supplying doctors for the world now. Although they are poor, they give all the doctors. Most of the places in the world are now full of people who have been trained at great expense in India or wherever else. And I don't think we can change this, but we could change what happens with those who are at home, what happens with the community members, not the community as a whole, because as I said, community as a whole has changed in its nature. It's not any longer as cordial and as close as it used to be.
Thank you for your comprehensive answer. Maybe we can take some few more questions from the audience.
Yeah, can I-
Dr. Renner is having a question.
Yeah, I invite others as well, but so I keep my questions short. So what about the, Norman, you just talked about mental health in general, but I think what we see very often is, we have, I think due to the medication, things have changed, and sometimes the support is much shorter. So you can have people who are treated for a while and then it's shorter, and the medication has done a lot of that. So if you can comment on the differences of the diseases and what they differently need in this model. And the other thing is, I'm currently having the experience of being just involved in the care of my parents. And interestingly, my father, who's 88, now has to organize care, and what he's really struggling with is all this paperwork and the numbers he has to put on the computers and all this stuff. And he has commitment for my mother, but it's the management is extremely difficult. And I think there's lots of admin stuff. And I just visited the nursing home, and going from one place into the nursing home looks simple, but it's an administrative burden, and so everything is extremely complicated in the administrative side. And I think this is part of our society. So what would you recommend on that?
Well, it's a wonderful example, I think, of the problem which is currently becoming obvious. People live longer, but they don't necessarily live a happy, healthy life. They get sick, they have diseases, they have more diseases as age progresses, so they become increasingly dependent on someone. It's quite clear that the doctor plays a role there, but the main role is not a doctor anymore. Here again, it's the carer who needs support. There's wonderful work that Dr. Brodati has done in Australia about what needs to be done to keep the carers alive, to keep the carers functioning, to keep the carers healthy. It's not easy. But I think that is probably where we have to think. But there are other things now which we could or should emphasize. For example, most of the elderly people, speaking about the old age as one example of that, most of the elderly people, in fact, are finding it very difficult to use electronic devices because they are very complicated, and they are, for them, it's learning a new language. And you get this stupid advice on a variety of QRs and God knows what. They don't know what to do with this. So one of the lines of action could be perhaps the modern technology could be developed keeping in mind of who will use it, rather than to develop it because the most advanced people in the world can use it better. So I think that the emphasis on development of a simple technology that can be useful. I give you an example of simple technology, which I thought was wonderful. They have, in Denmark, they have put now a small wire into a little carpet in front of the carpet, a mat in front of the toilet of people who are elderly. And they expect that people who are elderly will step on that little carpet when they are visiting the toilet. But if they do not step on it for more than 8 hours, a bell rings in the service and says this person is not replying, so they can call him. So instead of waiting for 3 days half dead, he gets a call within 6 hours that he hasn't been to the toilet. And I think that the notion of having such tools, using the current technology which we are having to help people live even when their condition, when their capacities are diminished, is of tremendous importance. I think equally so, one has to help the, I mentioned already that in your instance, you were, maybe because you are working as a well-conditioned doctor, you can afford help of other people. It's expensive, but it can be done. But in many other places, we should think, can people afford the care? And if they can't, we should in fact consider it as normal that they are paid for what they're doing, not an exception. In some countries, they get a ridiculously small sum, which they are supposed to do it. Yet they're providing service which is equal to the best hospital service in the world. And we are saying, well, this is normal. It's not normal. It used to be by necessity normal. It's no longer that. Now that people are working outside of the house, it is normal to expect that expenses have to be covered and help them, particularly in a society in which everything is measured by money. And the care is no longer possible. The minister says, we are looking after everybody and my staff are wonderful. He should also pay some money to help these staff survive. So my sense is we should use the modern technology, if at all possible, to a degree. We should recognize the need for care and the need to help carers as such. And we should also revise our instruction manuals, which govern what we are doing about people when they're not well. And multimorbidity is a huge problem that sort of sits above everybody, because your father maybe is lucky to have only one problem, but most people have a cardiac proposition, a prostate that doesn't work, and 100 of other things for which they have to see somebody and do something about it.
Professor Roy Abraham is asking a question. Over
Yes.
to Professor Roy Abraham, sir.
Yes, Professor Sartorius, you have dealt with a lot of leadership in the world, political leaders. I would like to know from you, what's the best way? Is there any easy way to get the attention of the political leadership who makes most of the decision in the low and middle income countries? I remember I myself had an experience. I was the president of the Indian Psychiatric Society. When I obtained a session with the Union Health Minister at that time to speak about mental health problems, it was possible because my local MP, local member of parliament, was a friend of mine. I was treating one of his close relatives. And this MP happened to be in the parliamentary committee for the health ministry. But unfortunately, myself and my delegation we were sitting, he made some cursory remarks. Then there was a TV playing in his room, and his attention was on the news being scrolled there. But we had 30 minutes, probably he was listening to the TV news. He hardly paid any attention to what we are saying. Finally, he received our memorandum and said, I will do the needful. But nothing was done. This is not an isolated experience. This is how politicians deal with in the developing world. What can we do about it?
Well, number one, we should think of working with politicians as one normal part of our life and working hours. It is more useful to spend 2 hours with 5 parliament members than to see 25 patients. Because the 25 patients can be seen by people whom you have trained, and they can also be seen for a shorter time while you are thinking about ways in which the politicians and people in the government, etc., can be gradually attracted to the area. I'll give you one good example. A few months ago, one of the most extraordinary events happened. The United Nations have passed a resolution specifically directed to improving mental health in the world. The United Nations, first resolution since the United Nations came into existence. It's a 7-page resolution. Everything is in it. I asked at a recent Congress in Vienna, I asked about 40 of my colleagues. Not one of them knows that the resolution is out because they don't care about the United Nations or about whatever other organizations there are. And one should probably understand that the role of a doctor is to a large extent also of a role of an advocate for his people who are sick. And therefore, if you're dealing with politicians, you must use the same weapons which they are using. They talk about resolutions and decisions and laws and other things. And psychiatrists very often neglect to speak the same language and to read the right documents and to go to them and speak. It means that they have to take part of their time, maybe half of their time, to learn all these things and bang on the door of people in order to do something about it. It's particularly true this is for primary prevention. Primary prevention is entirely in the hands of mental disorder, in the hands of other people. Take the example, iodine deficiency in pregnancy leads to cretinism. All right? Now, none of the psychiatrists will ever go and give iodine to women. But it is his duty to make the bloody government, in fact, provide and show that they provided iodine to all pregnant women. But to do this, he has to bang on many doors, and he has to be much more of an advocate for his people, so to say, than is currently often the case. In a more modern situation, the tribune, the fellow who is looking after patients, must become the psychiatrist who is the agent who links the government lines with the needs of people who are mentally ill. In addition, he has to look after patients. But in addition, I think he must make sure that the government as a whole, or the society as a whole, provides the wherewithal to look after these patients, because otherwise he prescribes a medication and the patient either takes it or not, and that's the end of the story. They don't get well. The disease does not stop in a moment. The disease is there all the time. Looking after the disease is now becoming the least important part of one's work.
Thank you.
Dear Professor Norman Sartorius, thank you very much for your amazing lecture as always. So it's my honor to be here, and I would like to thank you for emphasizing the topics about psychosocial workers and the role of psychosocial rehabilitation, which really should take enough time in the treatment programs for our patients suffering from any disorders, either stress-related or psychotic heterogeneous disorders. And absolutely agree with you about the need to have advocates who would protect people suffering from mental illness. I'm working with my chancellor in the university, who is a surgeon, and I was appointed at my position 2.5 years ago. And finally, only after 2.5 years, he started pronouncing the word depression and anxiety in front of the council. And he started talking that we need to do something for people with depression because depression is rising. So I was absolutely impressed that finally I hear these words from the surgeon, from the chancellor, and he really started helping us with psychiatry. And recently we've been to Uzbekistan, and the president of Uzbekistan, by the way, Professor Shahnaza, send you greetings.
Thank you.
And yes, and she had very good reminiscences about your visit to Uzbekistan many years ago. Yes, and when president visited psychiatric hospital, it changed a lot. So they have impressive environment, and we visited this hospital, and they have everything: rehabilitation rooms, social workers. They have no such stigma. They have not so high fence. They have terraces for patients. They have shower with she for patients. Everything. So we were impressed. It was much better than the hotel we stayed in Uzbekistan, the psychiatric hospital. So it's especially when you say that we don't live anymore in a mutually supportive environment, it's very important now to advocate and support our patients who are suffering from mental illness. And I met Professor Miro Yakovlevich, who, of course, a big fan of you. And he was discussing his idealistic concept, but I like it very much, about empathetic civilization, because he thinks that it will help against mental illnesses in the world if we continue to support each other. If I still have a question, I would just like to ask about gender-specific services. What do you think about this? Because now we have also issues with gender choice and gender education and so on. And also we have a gap, and I know that European Parliament is now have suggestions from psychopharmacologists to change instructions for pharmaceutical drugs, which would be subdivided the prescriptions for females and males, because they are different, and really women and men differently react to pharmaceutical drugs and have different issues about immunity, because the genes which are responsible for immunity is an X chromosome, is located in X chromosome, and so women have more immunity, more efficient immunity, but they also develop more autoimmune disorders. So it should be taken into account when we are providing any types of treatment to females and male population, and specifically in psychiatry, including side effects and safety. Sorry for many words.
Well, I think what you said, which is one thing I didn't emphasize very much, it is the need to establish a different relationship with our colleagues in other disciplines. For the moment, they consider us that we are the least knowledgeable and the least helpful people in the world. And sometimes they are true, they are right, because we have forgotten that medicine has developed and we have concentrated on looking in psychiatry only, forgetting with theories like psychoanalysis and others, forgetting that science, meanwhile, is advanced, and we have not been able to speak to our colleagues in internal medicine and whatever on the same level, understanding the modern science of medicine as well as they do. So it's very important that we gain their respect by being up to date. And it's something that psychiatrists should be thinking about very carefully, because many of them are not really up to date at all. They know psychiatry of 20 years ago. They're very good at that, but the rest is being neglected. Maybe I think that I have another hope, speaking of gender, which is the current in a number of countries, the number of new psychiatrists is predominantly females. And my great hope is that they will improve psychiatric care greatly, because they may have more empathy and more a feeling of somehow of the need to look at various aspects of human life than the males had in the past. So that is a good thing. Particularly Turkey, I think, has been a good example, where there are two disciplines which are everybody gives priorities. One is psychiatry and the other one is dermatology. And when asked about dermatology, they say, well, we have to do dermatology because there are no night duties in dermatology and we have small children, so we want to stay with the children. But psychiatry, no, psychiatry, we want because we feel that it needs more of a sense of feeling, and that's why we want to do psychiatry. Our male colleagues are not doing so very well.